All right, hello and welcome. We're going to give folks a moment to join before we jump in. So I'll just give people another minute. Welcome, welcome. I can see folks joining. I'm just giving people a minute as we know it takes a couple minutes to switch between back-to-back meetings. All right, I'm going to start easing us in with some intros as people continue to join. Welcome to the first in our Grand Round series. My name is Claire Crivero. I'm the focal point for partnerships for the COVID-19 research database. I'm at DAVANT, but I work with the entire consortium of partners that support the COVID-19 research database project. And this Grand Rounds is going to be focused on vulnerable populations, the impacts that can be uncovered by using real world data. And the idea behind this Grand Round series is that we want to lift up, we want to highlight some of the research groups that are working with the database and give them a platform to share their insights, as well as some of the methodological considerations that they have in their work, as well as their findings. And I've selected 3 brave groups who will be sharing their work with us today, and I'm immensely grateful to them. If you are joining now and you are a researcher using the database, you may be getting a call from me. We're hoping to do this about monthly, but we wanted to start with this topic. It is very timely. I'm going to give us a little bit of framing around why this topic now, as well as a little bit about the database itself. We're going to talk about the intros when at the very end of the presentations of our panelists today, we will open up to Q&A. So before I get started, I want to draw everyone's attention to the Q&A feature in Zoom. Please use that early and often as our panelists present, but we're going to answer questions at the end of all the presentations, just so we can get through all of the slides, and then we'll take questions, and I hope you will early and often use that Q&A function. So vulnerable populations and why the framing around this particular topic for our first Grand Round series. I wanted to draw attention, I think, as we've been looking at all of these researchers onboarding to the database on health equity. It's something that beyond just these 3 groups, we have a lot of groups thinking about how to use real world data with a health equity lens. And that means, health equity. It means that everyone has the opportunity to be as healthy as possible. And we look at equitable opportunity, including equal access to and distribution of resources, preventative care, curative care, etc. And the why behind health equity, I don't think I need to outline this for everyone on this call, but I think the real why, just to put a finer point on it, is that when policies, programs, and systems support health in an equitable way, we see health outcomes, better health outcomes for the whole of society, for the whole of populations. And I think the framing around this is that we're in 2021, but we're coming out of 2020, and we recognize, like everyone in the community of practice recognizes, that the pandemic did not impact every part of our society, every part of our general population equally. We know that the indirect and direct effects of the pandemic were not equitably equally felt. And certain populations were inherently more vulnerable to adverse outcomes, a lack of preventative care, a lack of curative care, or perhaps increased morbidity, mortality, just by virtue of the population they were in. So the researchers we are featuring today aimed to stratify their analysis in a way that we can see inequities in the access to care or preventative services, or even that COVID-related morbidity and mortality. And these research teams are elucidating these possible inequities and how they might break down against race, ethnicity, gender, socioeconomic status, etc. So the database that they are using, I just want to frame for those of you who may not be familiar with the COVID-19 research database. The database was put together about a year ago by a consortium of partners with the idea that we should make more real-world data available to research teams, to non-commercial research teams. I think we all saw at the beginning of the pandemic, many pre-prints coming out, or publications, peer-reviewed journal articles that had very small populations, but really interesting science. So the goal was, how can we get bigger populations of interest available to these researchers to run their studies on? So a year later, we're looking at 87 billion records in total that are available in the database, about 250 million unique individuals. We have many researchers, over 2,000 researchers registering the database. Of those 2,000, 210 groups have submitted proposals. We have 160 groups currently in flight, which means at any given time, about 500 researchers actively working with provision data. And the data they're working with include the 55 public data sources, so people can bring in public data as long as it's being available to the wider research community, 13 major private data sources, and this is all made available at zero cost. We have incredible representation from the public sector, academic medical centers, government organizations at the state, local, federal level, as well as international researchers. And I can't go any farther without recognizing the partners who make this possible. These are the partners who jumped in, who said, yes, we should make pro bono access to these resources possible. Not only just the data, but also the infrastructure that supports us scaling from 5 researchers to 500. And with that, I want to pause for a moment and take a quick poll so we can get to know who's here today. So if you could just help us understand so we can make sure that our messaging is as tailored as possible to our audience. What best characterizes you? Are you not using the database, but considering using it for future work? Currently a researcher with the database, or are you just here because you're curious about the topic, about the database itself? We'll give people a few moments. Thirty seconds or so. All right, not using the database. Okay, so this is helpful. So I might just dwell on one point really quickly about the resources in the database. So this is a real world database, which means that I think as an epidemiologist, I worked a lot with big surveys with a very, very precise sampling methodologies, et cetera. Real world data means the data that you interact with as a patient in a system, or even as just a human in society. That means your EHR data, your electronic health record data, or your claims data. I think that's the main big areas of data that we're going to hear our researchers talk about today. Just want to frame that for you because there are pros and cons to real world data. Obviously, there's immense amounts of it. I think that's where that 87 billion records available in the database come from. Obviously, when you're capturing an entire patient journey, a lot of data is generated. That being said, it's not the perfect data, right? It's not a perfect survey with perfect sampling and perfect completion of every variable. You get sort of what is available in the real world. So I want to just frame that because I think a lot of people aren't using the database yet and want to make sure that we're clear on what we're talking about when we talk about real world data. With that, I want to just introduce our panelists. So I'll call out their names. I want to get them to give just a little bit about who they are, where they work, in their area of focus. So we'll start with G. Can you introduce yourself?
Oh, hi, my name is G. I had a not-for-profit AI and data science research group with about 30 data science worldwide. We're volunteers. We work at places like Blue Cross Blue Shield, CMS, some are Hopkins, all over the place. We just donate our time, and this database has been a gold mine for us, despite our access to other stuff at our day job. So this has been awesome.
Great. And Laura?
Yes, hello everybody. My name is Laura Smith and I'm a research associate at the Urban Institute in the Health Policy Center there. I recently received my PhD in health services research at the University of Minnesota and joined Urban Institute last summer. I'm currently working on a couple different studies related to outpatient care and telehealth use and equity during COVID. And in a lot of my research, I use large claims and electronic health records data sets.
And Smeed, Dr.
Hi, everyone. My name is Smeed Katana. I'm an instructor in the Division of Cardiovascular Medicine at the University of Pennsylvania, and I'm a practicing cardiologist at the Philadelphia Veterans Affairs Hospital. I do a lot of work around health disparities, health innovation, yeah, so this is in line with some of the work that we've done previously.
Great. So I think with that, I will hand the microphone over to Laura. And again, a reminder, use the Q&A function as we move forward, and we will get to all those questions at the end.
All right, thank you, Claire. Hello again, everybody. Today, I'm talking about a project that uses data from the COVID-19 research database to examine preventive care use during the pandemic. And this is a project I'm working on with several of my colleagues from the Urban Institute, including Luis Lacerto, Fred Blavin, and Lisa Dubé. Next slide, please. I want to start by providing some context for this work because what I'm presenting on today is part of a larger mixed methods project funded by the Merck Foundation to study preventive care use and health-related social needs during the pandemic. with a particular focus on differences across racial and ethnic groups, as well as patients with different types of insurance. While today I'm going to be focused on the quantitative data analysis component of this work, the larger project also involves a community advisory board and focus groups, which are incredibly important to ensure that community members and stakeholders ranging from medical providers, social service providers, and advocacy groups are all involved in and contributing to the research. Next slide, please. As we all know well by now, outpatient and non-emergency healthcare use declined dramatically during the early months of the pandemic last year. And this decline was partially offset by the emergence of telehealth as a novel channel to deliver healthcare. But not all care can be provided remotely, including many preventive care services such as mammograms, Pap tests, and colonoscopies. There were many dynamics at play during the early days of the pandemic that influenced preventive care, such as stay-at-home orders and even closed medical practices. Disparities between racial and ethnic groups in access to care may have also been affected by systemic factors. So for example, restrictions imposed on public transportation may have created increased barriers to care for those who rely on public transportation to access their healthcare services. While we know that Black, Latinx, and Indigenous people died from COVID-19 at disproportionately high rates, we have a limited understanding of how patterns of preventive care use during the pandemic varied by race and ethnicity. And this is in large part due to limited availability of data to describe these patterns. Many commonly used data sources, such as traditional claims data sets, experience significant lag and are not typically available to researchers in real time. And moreover, race and ethnicity information is often not reliably collected or is missing entirely from these data sets. So last summer, when our team was crafting the aims for this project, the COVID-19 research database presented an opportunity for us to use data that was timely and also included race and ethnicity information to enable analysis of differences in use of care. Next slide, please. So our data analysis addresses two primary research questions. First, how did rates of preventive care use change during the first 9 months of the pandemic, or March through December 2020? And second, how did patterns vary for patients of different races and ethnicities? And eventually we are hoping to study a range of preventive care services, but today's presentation is going to be focused solely on screening mammograms for breast cancer. Next slide, please. We use the Veradigm Allscripts electronic health record data from the research database, which includes de-identified EHR records from ambulatory care practices located across the country and includes data about patients covered by all different types of insurance. We chose this data set from the research database because of its large sample size and its inclusion of patient race and ethnicity information. Our main sample included a consistent panel of nearly 10,000 providers who provided patient care throughout 2019 and 2020. After identifying this panel of providers, we then used CPT procedure codes to identify screening mammogram orders. Our analytic sample included over 1.6 million mammogram orders for about 950,000 different patients. Since this is obviously a brand new data set for a research team, we spent a lot of time cleaning the orders data table, something that I'm going to expand upon a lot in the next slide. But once we got the data to a place where we felt like it was ready for analysis, we first examined overall trends in mammograms during 2019 through 2020, and then calculated year-to-year percent changes by race and ethnicity, using the race and ethnicity as it's recorded on each patient's EHR record. Next slide. So I do want to take a minute to elaborate just a little bit on an example of the type of data cleaning that we did. One important step in our process was to deduplicate the orders data table to ensure that we were not double counting or even triple counting mammogram orders. So after querying or pulling all mammogram records ordered by the providers in our panel, we found that many patients had multiple mammogram records appearing on different dates within a very short time frame. And it's unusual for patients to actually have more than one screening mammogram in a short time period like that. So to help us decide which duplicate records to keep and therefore which date to assign the mammograms to, we used a variable called order status. The different values for order status are shown on the left-hand side of the slide, sort of in descending order of how often they occurred. And so while some of these values are very straightforward, Others, like those that are just a single letter, are more difficult to interpret. But we further noticed that often, though not always, there was a predictable progression in subsequent records for a given patient. Specifically, an active mammogram record was often followed by a resulted record, which was sometimes, though not always, followed by a completed record. And the fact that this progression of order statuses was not entirely consistent may indicate differences in how providers use the EHR or in how reliably EHR records are updated to reflect active versus completed versus resulted orders. Okay, now turning to the flowchart on the right-hand side of the slide, just summarizes how we ultimately cleaned and deduplicated these data. So after identifying all mammograms and excluding those with a status of canceled, there were 3.7 million records remaining. However, if we kept only one record per patient and per order ID using hierarchical logic based on the status variable, that cut the sample down by more than 50% to about 1.6 million. And we treated this as the primary analytic sample, but in sensitivity analysis, we further restricted the sample to only those orders actually marked as completed, which cut the sample size down again to about 1 million. Ultimately, though, the resulting analyses looked largely similar across all three of these samples, so that reassured us that the overall patterns were not super sensitive to which logic rule we applied here. Next slide, please. So before showing the main results describing patterns in mammogram orders, I want to talk about this graph, which displays the race and ethnicity distribution of all mammogram orders each month throughout the study period. So kind of the key thing to notice here are those green segments of each vertical bar, which represent the fraction of orders for patients with an unknown race and ethnicity. These unknowns comprise about 20 to 25% of all mammogram orders each month, and the fraction is actually shrinking a little bit over time and is smallest in the latest months of 2020. In these unknown cases, this meant either the patient record was missing entirely from the Allscripts database, or there is a patient record, but the race ethnicity information is missing from the record. Unfortunately, this does kind of limit our ability to draw definitive conclusions about how mammogram patterns varied by race and ethnicity, because we can't know the true race and ethnicity of patients with unknowns, and we also can't assume that all races and ethnicities are proportionally represented among the unknowns, and the unknowns occurred widely across both providers and geography. So this is just something important to keep in mind as I move through the main results from our analysis. Next slide. Here we show the total number of mammogram orders by month aggregated across all races and ethnicities. The blue line here represents 2019, while the yellow line represents 2020. As you can see, in January and February, the first 2 months of the year, we see very similar counts in 2019 and 2020. But then in March and April, we see these dramatic declines in 2020 compared to 2019, which of course coincides with the start of the public health emergency. By about June of 2020, though, mammograms catch back up to the 2019 levels and even exceed them in some months later in the year, which we might expect to see if people are making up for healthcare that was missed during earlier months of the pandemic. However, the slightly higher 2020 numbers in the later months of the year do not entirely compensate for the losses between March and May. Overall, there was still a net loss of about 52,000 mammograms in 2020 relative to 2019. And then just two other quick points of interest about this graph. So first, you may notice that July is missing from the horizontal axis, and this is just because of an unexplained missing data issue where for some reason a significant volume of data are missing from the database in July of 2020, so we've excluded it for now. And then the second thing is that there's a kind of noticeable spike in mammograms in October, and particularly in 2019. And interestingly, October is Breast Cancer Awareness Month, and other studies have actually documented an increase in mammograms during October of prior years. So we were glad to be able to replicate that finding and sort of explain that spike. And so on the next slide, I'm going to essentially be breaking down the difference between those blue and yellow lines in each month by race and ethnicity. So here on the horizontal axis, you once again see the months of the year, but now the y-axis is the monthly percent change in mammogram orders from 2019 to 2020. And each different colored bar for each month represents a different race and ethnicity. So what we see is that there are some small changes in January and February 2020 relative to 2019. But once we get into March and April, once again, all race and ethnicity groups saw significant declines in the volume of mammograms. And by the last several months of the year, all race and ethnicity groups were seeing increases in 2020 relative to 2019. One thing to note here too is that the sample sizes are not the same for each group. So the height of the bars represents percent changes. So some of the sort of unexpected swings, for example, the pink and green bars in January and February, may be due partially to relatively smaller sample sizes. So we do observe apparent relative differences across race and ethnicity groups in mammogram use during the pandemic, but we are hesitant to draw any definitive conclusions here about how patterns change differently for different races and ethnicities, because we know that up to a quarter of records have an unknown race and ethnicity, and also that share of unknowns is shrinking over time. So this incomplete race and ethnicity data is an ongoing sort of challenge for our team. Next slide, please. So in addition to the unknown race and ethnicity, another challenge for us is that the lack of a patient denominator file in this data, which makes it difficult to know who all is represented in the data. Rather, the data represent care provided by the office-based providers who use the Allscripts EHR software. And this may not be representative of all patients or all providers, which just means we need to be mindful about generalizing these findings to broader populations. Next slide. Despite these challenges, though, it's extremely important and valuable to have this rich real-time data source from the COVID-19 research database, and we're looking forward to continuing to refine our analyses using these data. We're also planning to expand the analysis, of course, to include additional preventive care services, such as colonoscopies, Pap tests, maybe childhood vaccination. And we're also going to continue our engagement with our community advisory board to help contextualize and interpret any patterns that we see. And then finally, just wanted to call out that in some related work using the HealthJump EHR data, also from the COVID-19 research database, we're actually linking EHR data with consumer data that includes measures of patient income and education to hopefully be able to examine patterns by these characteristics as well. I think that's all for me. So thank you so much for attending, and please do reach out. Feel free to reach out directly if you have questions or suggestions for us.
Great. Thank you so much, Laura. I certainly have questions. Please feel free, any questions you have, put in the Q&A. But I think with that, we'll move on to our next panelist. So Sumit, I will pass the mic.
Great, thank you. So today I'll be talking about a project that is recently completed. I'm working with a team here at Penn, and it's called Predictors of Telemedicine Use During the COVID-19 Pandemic in the United States. So next slide, please. Here are my disclosures. Next slide. So as Laura mentioned, there were some dramatic changes with the onset of the COVID-19 pandemic, specifically related to telemedicine use. Prior to the pandemic, reimbursed telemedicine was more or less non-existent in the US, related to several requirements that payers impose on providers in terms of what types of services would be reimbursed and what settings patients need to be in. And primarily it was focused on rural areas and certain facilities. However, in the midst of stay-at-home orders at the beginning of the pandemic, CMS, on an emergency basis, allowed for the reimbursement of telemedicine visits at the same rate as face-to-face visits for a much broader range of circumstances. And a lot of, most I should say, private payers, as well as state Medicaid agencies followed suit. And so that led to a dramatic increase in telemedicine use. And so this figure here is from a paper that came out last year, which used a commercial insurance claims database for the first 6 months of 2020. And the yellow dots at the bottom of the figure show telemedicine visits. And we can see that prior to week 11, which is roughly the end of March, telemedicine was a very small component in this database, at least, of overall encounters. And we see this dramatic increase peaking at around 30 visits per 1,000 members around April of 2020, followed by a slow gradual decline, but it continued to be a significant proportion of overall visits by the end of this study period. So next slide, please. This is from the same study, which also looks at some geographic heterogeneity in the proportion of patients or members living in different states and how many of them had telemedicine encounters. And the states that are shaded in the darker shades of blue are the ones that had the highest proportion of members who had had a telemedicine encounter. And we can see that those states are mostly in the Northeast, a few parts of the upper Midwest and the West Coast, versus states or many states in the South and other states in the Midwest. The ones that are in this lighter shade of blue had the lowest proportion of members who had had a telemedicine visits. And we all know that there are large gradients in several important demographic and socioeconomic variables between states. So this already gives us a hint that utilization or access to telemedicine wasn't even across the country, at least in the early parts of the pandemic. So next slide, please. So just as an aside, there are several examples of disparities in access to medical innovations. So here are a couple examples from my field, which is cardiology. In the first panel, this is a study that we did at Penn looking at the use of a new class of medications that was approved by the FDA over the last few years called SGLT2 inhibitors, which are used for diabetes and certain types of heart disease. And we can see in these trend lines that patients who are Black and Asian were significantly less likely to be prescribed these medications for several years from 2015 to 2019. And in the second panel, which is looking at the proportion of patients who had access to a particular type of novel prosthetic heart valve, what we see is that the proportion of Hispanic and Black patients who received this device was significantly lower than their overall representation in the population. So this idea that whenever we innovate in medicine, it sometimes exacerbates disparities is something that's pretty well established, especially as it relates to medical therapies. So next slide, please. So what about telemedicine? So this is another analysis that we did at Penn, which was led by one of our cardiology fellows, Lauren Eberle. And this used data from our own health system, which consists of 6 hospitals spread across urban, suburban, and rural areas. And we had a sample size of about 150,000 patients who had completed encounters. And this is from March through May of 2020, so fairly early on in the pandemic as well. And what we see is that, so this is an odds ratio of having had a telemedicine visit, and we can see the forest plot as we go down. And we see significant differences in different patient groups in terms of access to telemedicine or utilization. The first 3 rows here, the main takeaway there is that older patients were less likely to use telemedicine. And then later on, we also see that Asian patients compared to white patients were less likely to use telemedicine, as well as non-English speaking patients who also were less likely to use telemedicine. There have been a couple other smaller single site studies which have seen various somewhat conflicting results when it comes to access and utilization and disparities, with different patient populations having various levels of utilization. So next slide, please. So the question is that expanding on these single site studies, has the pattern of telemedicine utilization been in different patient groups on a national level and over a longer period of time during the COVID-19 pandemic, and whether utilization differs by area level markers of social vulnerability. So next slide, please. So for our analysis, and I'll share a few details. I'll hold off on sharing all of the results because the results are currently under review. We used HealthJump, which is a data management platform which allows for interoperability across different EMR vendors like Epic and Cerner. It has about 40 million unique patients with data that's updated daily. And the data that was made available to us included data on encounters, comorbidities, medications, demographics, including race, ethnicity, and language. And we also had patient residence information at the 3-digit zip code level. And so that was one of the important factors which led us to choose HealthJump, is that we had access to, or at least some idea of where patients were living or using these services from. Next slide, please. So we first identified all patients in HealthJump who had had an outpatient medical encounter between March 1st, 2020 and December 31st, 2020, using CPT codes for outpatient encounters. We excluded CPT codes for encounters that were in certain specific places like emergency rooms or dialysis facilities because we wanted to focus primarily on outpatient care. And then we also used CPT codes to identify telemedicine visits. And so these are the 2 sets of codes we used. The first one was for audio-only visits, and the second one identifies audio-video visits. And I'll talk a little bit more about some of the limitations of the audio versus video issue. So in this slide shows what our overall study population was. We were able to identify around 2 million unique patients in HealthJump who had had an outpatient medical encounter from March through December of 2020. These patients had around 5.2 million encounters between themselves, and roughly 30% were above 65 and close to 60% were female. In terms of race and ethnicity, just like Laura mentioned in her study, there were significant issues around data missingness. So for race and ethnicity, 36.7% had missing information. And amongst the remaining group, 32% were non-Hispanic white, 8.7% were non-Hispanic Black, and around 13% were Hispanic of any race. And for language, we had around 32% missing data, and 55% were primarily English speaking. In terms of where a patient resided, so this is just using the US Census regions. What we saw was that the majority were living in the South. So 52% of these patients were in the South, 27% in the West, around 11% in the Northeast, and 8% in the Midwest. So I think this should already give us an idea that this is not a representative sample of the overall US population. For example, in the total US population in 2019, 38% of the population lived in the South. And so there are some differences based on where HealthJump is getting its data from. Okay, next slide, please. So in terms of telemedicine utilization, these graphs here show monthly proportions of unique patients receiving telemedicine visits. And so for this, a patient needed to have at least one telemedicine encounter to be considered having received telemedicine services. So amongst the 2 million unique patients, around 21% had had at least one telemedicine encounter during the entire study period. In these 4 panels, we looked at some interesting subgroups of patients. We saw overall similar temporal trends where there was a sharp increase in telemedicine usage early on in the pandemic in April, followed by a gradual decline and then a slow increase again later in the year, which possibly could be related to the various waves of COVID and sort of related stay-at-home orders. We decided not to necessarily focus on temporal trends. That can obviously get quite complicated and does require some more sophisticated statistics, but I think the takeaway here is, and this is unadjusted analysis, and in panel B, the second panel on the top, we see that overall women were more likely to have telemedicine encounters compared to men throughout most of the study period. And in the bottom, in panel D, the race ethnicity subgroups, the significant difference we see is this yellow line indicates Hispanic patients of any race, and we see a significantly higher proportion of these patients who had had a telemedicine encounter throughout most of the study period. I will say here, so this is after we used multiple imputation to account for the data missingness, and I will talk a little bit more about that, about why that's crucial if people want to study race, ethnicity, other types of demographics and real world data. So next slide, please. We were also interested in area level markers of socioeconomic status or social vulnerability. So there's several different types of indices, markers available. The area deprivation index is probably one that most people are familiar with. For this, we decided to use the CDC's social vulnerability index, which uses several US Census Bureau derived variables to create an index of social vulnerability where a higher number indicates a more vulnerable area. Since we only had 3-digit zip code of residence for each patient, we had to aggregate each of these variables, which are available at the 5-digit zip code tabulation area from the census, to the 3-digit zip code level and then recalculate the index. And so we did upload this to the COVID-19 research database, so this would be available for other researchers as well. Next slide, please. And so this shows the distribution of the social vulnerability index across 3-digit zip code across the US. And so what we see here are that the 3-digit zip codes in the darkest shade of orange/red are the ones that are the most socially vulnerable. And so those are large parts of the South, Southwest, some border areas in Texas, as well as metropolitan areas in the North and Northeast, including Philadelphia. Next slide, please. So lastly, I want to talk about some of the methodological issues that have come up during the analysis. So a major one is obviously data missingness for race, ethnicity, and language. And this is something that plagues most real-world data sources, whether they're administrative claims data, EMR data. And obviously the level of missingness is going to vary from data set to data set, but 30 to 35% missingness is not an unusual thing, especially in real-time data, which is what HealthJump was. And so we had missingness for about a third of our patient population for these variables. And so we decided to use multiple imputation using patient and area level variables to impute these factors. And so obviously there's a lot of assumptions around multiple imputation. Namely, one of the most important one is that the data is missing at random, conditional on the variables in our model, which can be a questionable assumption, but is one that has to be made for multiple imputation. And there are ways to assess whether that assumption is a reasonable one or not. I will say that analyses that just omit patients with unknown data are shown to be more biased. And so I think any robust analysis of these kind of issues and this kind of data will require some method to account for the data missingness. So moving on, the other issue came up was comparing audio versus video telemedicine visits. In our previous analysis where we used our local health system data, we had an indicator variable which showed that whether the counter was a video visit or an audio visit. However, here we use these CPT codes, which I had mentioned previously. However, on review of the literature, we found that there has been a lot of issues with misclassification of audio versus video visits using CPT codes. And so we decided not to do a comparison comparing the two different types of telemedicine visits with each other. Also, Medicare is the one payer that really requires a differentiation between audio versus video visits, and we didn't have the patient's health insurance payer information available. So we couldn't necessarily do like a subgroup analysis of just Medicare patients. We could theoretically do 65 and older patients, but I think once again, we would be making certain assumptions that would be untestable. And then patient residence was only available at the 3-digit zip code level, which is obviously more granular than a state level, but it's definitely less so than 5-digit zip codes or neighborhood levels. And also, we did find that the boundaries of 3-digit zip codes are somewhat bizarre, especially in less populated areas where they oftentimes include areas that are not contiguous with each other, especially in places like Alaska and parts of the West. One thing I'll point out, whenever doing these kind of analyses, especially on a national level, one thing that needs to be taken into account is clustering of the data at various levels. So for example, we can imagine we have encounters that are clustered within patients, or clustered within clinics, clustered within states, et cetera, et cetera. And choosing that right level of clustering depends on the question you're interested in and obviously the data that's available. For us, we did cluster at the clinic level. However, because patients, or sorry, I should say provider level, but since patients did have multiple providers, we did have to make some decisions about how to assign a provider to a patient. We ended up using the first encounter that patients had, so the first telemedicine versus the first non-telemedicine encounter. However, there could be other choices that we could have made, including the providers that a patient saw the most often, et cetera. And lastly, I'll say, since our interest was on patient characteristics, we focused our analysis on the unique patient level rather than the encounter level. However, for other types of questions, it might make more sense to focus on the encounter level. I think, yeah, one other thing I do want to point out is if people are doing longitudinal analyses, which I think many folks are interested in doing, that's another thing to take into account, seasonality and other clustering on a time level that are important to take into account. Anyways, I'll stop there and I'm happy to answer questions later during this talk.
Thank you so much. And so with that, I'll hand it over to our final presenter. I'm going to stop my share and let G share her screen. And
All right. Hold on, let me try to get stuff out of the way. So this is where Claire left off. All right. So our topic of the day is COVID illness burden, and that's infection risk, death risk, by race, gender, and a bunch of social determinants of health. As mentioned earlier, we are a bunch of volunteers from all over the place. We just donate our time and having a great time with the consortium data. So these are the direct contributors for this particular study, but we've got several other team members supporting the COVID stuff. And we do other stuff like privacy and virtual reality, augmented reality, usually, directly related, indirectly related to AI, big data. So now the COVID infection risk, let me put on the presenter mode. Because we mostly work with the claims data, so the infection as we defined is not test positive, but somebody have serious enough COVID to result in the claims. So that in and of itself, it's a bit of a severity indicator, above and beyond just having COVID and have mild symptoms or asymptomatic. And then the COVID death is somebody who died after having contracted COVID, but not necessarily caused by COVID. So this particular study, we are using a sample size of 14 million people. They are at the intersection of 3 data sets. Medical claims from a claims clearinghouse with 110 million members and up to 70 years of claims history. But we select the subset that's, those about half of those people have claims during the pandemic, 04 to 04. That's how we make the cut. And then we have the social data from the analytics IQ. That's about 95% of the US adult population. And the company does some pretty awesome work and give us many dozens of interesting social attributes, and we picked out a few for this analysis. And then DataVant has their mortality index, about 80% of the US death. So this particular study, at the intersection of the 3, we identified 14 million people. In addition, we also have HealthJump and other data to do some supportive study. So both Laura and Samit talked about the utility and nuance of the data, and certainly we feel it. And also, as mentioned, a lot of us worked at insurance companies, CMS, providers. So the data, the real world data is always messy. Now, this particular data set relies on some sort of fuzzy matching of people across multiple massive data set. So its strength is certainly very broad and very rich. However, though, take claims, for example, the claims coming from claims clearinghouse, they lack the complete longitudinal medical history compared to claims from payers. And then some usable attributes are obfuscated for privacy reasons. And then data distribution, as Samit mentioned, does not necessarily represent the US population. So this type of data in our mind is actually great for generating signals, and there are various calibration methods to calibrate it up against across a broader population. Similarly, we can generate signals here to be cross-validated against other smaller but deeper data sets. For example, some of our collaborators at Hopkins, they have very deep 5 hospital center EHR data. We generate some signals we can throw over the wall for them to validate, and vice versa. Similarly, like my day job, I work for Blue Cross Blue Shield. So there's some interesting cross-validation that can happen. For now, let me jump to some of the descriptive analysis before I get into modeling. So this is our A3AI's website. We at the homepage, we highlight a few things since May is the race ethnicity month. So we are looking at here the COVID infection and death by race and age. So this chart is the infection chart. We pick out the 5 genders, 5 races. So infection, as you can see, and this is actually consistent with a lot of other findings in the literature, that Hispanics have quite a bit higher, 3 times almost higher rate of infection as Caucasian, followed by Native American, Black, Asian, and then Caucasian. Now on the death front, though, it's kind of interesting. Let me put it at the log scale. Once you get infected, though, that seems to treat everybody quite equal. And there's a lot of causal studies yet to be done, and we've done some, why that is. but infection seems to be more associated with the social, economic, job and stuff like that. Now, here's another view on COVID infection. Out of the um, analytics IQ, where those five a bunch of social attributes were pulled from. So we picked out a few just to look. For example, income. If you look at African American, Hispanic, Caucasian, Native American, and Asian, and then you plot them against, the income scale. Now the size of the dots are the infection risk as we defined as having claims. Now the green dots are women, red dots are men. So you can see that it lined up almost linearly, the income level as opposed across the racial of another a racial divide. And then men in general have a higher rate of infection than women. And then if you see these big dots, right, Hispanic again showed up as the biggest dot that have highest race. So we're curious about then, what about education then? So over here, the general trend prevail, except that Hispanic have lower education level than the others. Now, if you look at BMI, interestingly, the trend comes down this way. So African American BMI all the way down to Asian. Stress is kind of interesting. You can see the stress, but at least women seem to be stressed out quite a bit more than women. Maybe it's just they're more vocal, communicative about their stress. But this chart shows the stress comes from, again, the AIQ data set. It's a combination of self-report survey data and some sort of derived information from behavioral consumer data. So I thought that's interesting. Now, underlying medical conditions, we picked about 30 underlying medical conditions and count how many, on average, these people have underlying medical conditions. These are the usual, the diabetes, the heart disease, COPD sort of thing. So you can see there's an interesting thing there. Now, ER visits, in insurance speak anyway, ER visits usually is an indicator for poor health behavior or underutilization of preventive care. So you can see the ER visits comes down when you go from African American to Hispanic, Pacific, Native American. Now the Asian and Caucasian have lower rate of ER visits. So since income has such a big correlation with COVID infection, so we started to take a look at income. So the x-axis is the US household income in 1,000. So you can see that BMI has a negative correlation with income. COVID infection is this way. There's these wellness score, wellness score goes up with income. The chronic conditions, it's about the same. I think there's a lot of factors to be teased out, right? Because maybe the higher income people tend to be older. Therefore, even though they have better wellness scores, a better BMI, they're just being older, so the chronic conditions does not necessarily directly go up or down as your income. And then ER visits, again, unsurprisingly, goes down as one makes more money and have probably healthier, more preventive care. So so that's that. Let's go back to we are in collaboration with The Economist magazine to work on a piece to be published in a few days. So so we won't steal that thunder, but just suffice to say, to mention that we're also doing a stepwise regression on COVID infection risk factors. So it seems pretty obvious that these infection, a lot of these factors contributed to the race disparity on COVID infection, but how so? So our colleague at The Economist magazine has an interesting hypothesis. Let's try to peel the layer of onion and just use these stepwise regression almost as an explainer model to start control for nothing and look at the odds ratio of people getting infected. And then you kind of go down that scale, you start layering in jobs and income and education level and housing factors. Do they have religion practice, politics and age and gender and stuff like that. So for those of us who have a subscription, if you keep an eye out for this article coming out in a few days. So that's it for me. Any questions?
Yes, I think we certainly have some questions that have already come in, and we've been trying to answer them as they come in. But quickly, Jean, I know we preempted this in preparation for this Q&A session to get the Q&A started. You also did some work on telehealth, telemedicine from a claims perspective, and seeing as we've touched on that in each of the presentations, I was wondering if you could share a little bit about what you saw and how your team wrangled with claims data, specifically looking at telemedicine, telehealth.
Right. And this is just, getting a little nerdy here. I just wrote this is like 5 minutes before the presentation starts, since the other panelists talk about telemedicine from the lens of EHR. So we look at claims and unlike EHR, somebody might have an appointment who may or may not show up for telemedicine. In claims, somebody actually did pay for this. So chances are pretty good that they actually did show up for the appointment. And, don't have time to do pretty charts, but you can observe out of the this claims data warehouse's 3 billion claim service line items over the last 5 years. You can see it's been pretty steady. In 2020, there's about a 40% jump in telemedicine visits as well. And then Q1 of 2021, that trend is going to continue. I think 2021 and 2020 volume is probably about the same. So there's, consistent with the other researchers' findings, there's definitely a higher rate of telemedicine usage, and we hope this trend would prevail. Now, the other thing is, even in the scheme of things, 57 million claims seems like a lot, but out of the 3 billion, we're still talking about 2%. So it's telemedicine overall is still pretty underutilized. Now, to zoom in deeper, you can get into audio, video, this different kind of telemedicine. Now, the kind of telemedicine we found of the subcategory that jumps a lot is in this category of telemedicine procedure modifier and claims data, where stuff that may otherwise not have a separate telemedicine billing code. They keep whatever that procedure code is, but they add on this modifier of 95. So it looks like in this subcategory, there's a huge jump in the last year or so. So just different angle at looking at the same stuff.
Thank you, Jay. Thank you. And I want to jump now for a quick question for Laura in particular, because I think specifically following up on the idea of imputing, you really touched and featured on the missingness problem and whether missingness is informative or uninformative, and how, and at least visualizing it. Like here we can visualize that big missing or other chunk of the self-identification. And I'm wondering, following on Sameed's presentation about the imputing, how you all are thinking about imputation perhaps, or I know you're also looking at using that linked data. You talked about it seems like G was using those fields from other data sources to pull in race and ethnicity. I'm just wondering, from your perspective, what is the strategy there? Is there anything additionally you guys are doing methodologically to address that big chunk, that gap? We can't hear you. We can see you talking. Can't hear you. No worries.
Okay, now can you hear me?
Perfect.
Okay, I had myself double muted. So it's a great question. So one issue with imputation for us is that about half of the patients with an unknown race and ethnicity don't even have a patient record in the patient table. So because of that, we don't even know their zip code or anything about them. So it's hard to impute without any sense of where they live or any other characteristics. We have thought about potentially imputing based on the location of the provider, which is only really available to us by sort of backing into it based on the location of other patients that the provider is seeing, if that makes sense. So it'd be a little bit of a more complicated process. We have talked about doing it, but we also think that one important contribution of our research is to highlight how these data sources still do have this high rate of missingness in race and ethnicity, and how that can, we need to continue to push for better data. We need to continue to prioritize collection of race and ethnicity information that is accurate for every patient.
Perfect. And before we let you go, another thing I picked up on your presentation, this community engagement, that you're talking with the community members about your work, both on this study, but in the broader study that you're working on. And I think that's really important for real world data. I think there's a lot of conversations about how to bring patients to the table and how we're using and wrangling, particularly in this area. I'm just wondering if you can share any little bit more about is that engagement ongoing right now? And are we specifically talking about the use of real world data and those subcategories? You touched lightly on it, but I just want to double click on that.
Yeah. So we've been meeting with a community advisory board. I think we've met with them twice so far. And so the first meeting was more high level, just what types of healthcare services should we be even looking at or focusing on in our research? What are the important things to study sort of at a high level? And so that conversation was mostly focused around which preventive services we might look at first. And the second conversation was actually more focused on the focus groups that are happening separately. So we're anticipating our third meeting next month, and we're actually going to be talking more specifically about this quantitative analysis and sort of bringing them up to speed on what the data looks like that we have and what we've done so far, and hopefully working together to talk about next steps with their input. And I also thought Samin maybe had a comment about the last question too, about imputation.
Yes, please, yeah.
I was going to say, even the data that is available in terms of race and ethnicity, it's not clear in EMR how that's derived, because it's not necessarily true that it's always self-identified race and ethnicity. Sometimes it's just someone who's filling out these fields, assuming what someone's race and ethnicity is. And so that's another sort of caveat to keep in mind, that there could be misclassification even in fields that are available.
Okay, super important. I think, and thank you for highlighting both that classification, but also the issue of how telemedicine visits in general are classified, that we have to take into consideration that there is some user error here. And I wanted to, for you, Sumi, to talk a little bit about maybe, I know we don't want to scoop your paper, but if there's any further things that this has led you for, is there any further analysis you are doing sort of building off of this? Are you taking it back to your clinical research? Yeah, I'd just love to hear a little bit more about what might next steps for your study look like.
Yeah, I mean, I think another thing that we have actually analyzed in HealthJump is comparing overall visits compared to the year prior. It's a little bit more complex in terms of taking into account the longitudinal nature a little bit more. But there we have seen some interesting results about which sort of patient populations have had increases versus decreases in overall outpatient encounters. And I think another sort of natural next step is, what are the consequences of telemedicine? There was a very nice paper in Health Affairs in April, which showed that telemedicine visits for respiratory complaints led to increases in in-person visits later on. And so I think this idea that telemedicine is going to be a panacea for like cost control might not necessarily be true. And so I think some real world data sets like HealthJump and others could lead to sort of understanding some of those things as well.
Really important. Thank you for that. And then, G, a final question. There's a question as to why you might think that the estimates for COVID death risk by race and ethnicity differ so significantly from CDC estimates. Do you have any ideas about the sort of the limitations of the data that might have led to those differences?
Yeah. For one, the fact that these people have claims versus test positive, right? That the denominator is different, and then also. Again, refer back to the earlier data distribution problems. People who have insurance maybe tend to be more established sicker, in different parts of the country. So in some other study we've done, we actually did calibrated with CDC data.
Got it. Wonderful. Thank you for that insight. I know we have 1 minute. We're right on time. So with my last 30 seconds, I want to thank our panelists so much And I know we didn't get to every question. We've taken them down. I will try to reach out directly to those who asked questions we didn't get to and make sure that you get an answer. And thank you for joining us today. And please join us for our next grand rounds. It should be next month, and we will be sending out emails and publications about that as soon as possible. Thank you again, everyone. Have a great day.
Thanks. Bye.
Thank you.